Good morning and welcome to the lecture on Abdominal and Genitourinary Injuries, Chapter 28 in your text. After you complete this chapter and all related coursework, you will understand how to manage a patient with abdominal and genitourinary trauma. You will learn how to recognize life threats associated with these injuries and the need for immediate intervention. The curriculum includes detailed anatomy and physiology of the abdominal and genitourinary systems, as well as the pathophysiology, complications, assessment, and management of abdominal and genitourinary injuries. The assessment section is very comprehensive and follows the primary and secondary model. Specific injuries discussed include blunt versus penetrating mechanisms of injury, eviscerations, impaled objects, injuries to the external genitalia, vaginal bleeding secondary to trauma, and sexual assault. Emergency care skills include management of blunt abdominal injury, penetrating abdominal injury, and abdominal evisceration. According to the National EMS Education Standard Competencies, the EMT will be able to apply fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Specific to injuries regarding the abdominal and genitourinary areas, you will be able to recognize and manage blunt versus penetrating mechanisms of injury, eviscerations, and impaled objects. Specific to the pathophysiology, assessment, and management of solid and hollow organ injuries and blunt versus penetrating mechanisms, as well as eviscerations, injuries to the external genitalia, vaginal bleeding due to trauma, and sexual assault. The abdomen is the major body cavity extending from the diaphragm to the pelvis. It contains the organs that make up the digestive, urinary, and genitourinary systems. Some organs within the abdomen are better protected from injury than others, and it is important for you to know the anatomy of the abdominal and pelvic cavities and where organs are specifically located. You also must understand the functions of the organs so that you can assess how serious the injury may be. Approximately 8% of all significant trauma involves the abdomen, and injuries to the abdomen that go unrecognized and are not repaired in surgery are a leading cause of traumatic death. And this is specific that you should know that 10 to 20% of all trauma patients have some form of genitourinary tract injury. It is important that you realize the abdominal cavity is divided into quadrants, and there are 4 general quadrants. They are the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. You need to note that when we refer to right and left, we're talking about the patient's right and left, not yours. The quadrant location of bruising or pain can delineate which organs are possibly involved in a traumatic injury. Organs commonly found in the right upper quadrant include the liver, the gallbladder, the duodenum of the intestines, and the small portion of the pancreas. Organs found in the left upper quadrant include the stomach and the spleen. In the left lower quadrant, the descending colon and the left half of the transverse colon. And in the right lower quadrant, we have the large and small intestines, and the ascending colon and the right half of the transverse colon, as well as the appendix. The right lower quadrant is a common location for swelling and inflammation, and the appendix is a source of infection if it actually ruptures. The abdomen contains hollow and solid organs, any of which may be damaged. The hollow organs of the abdomen include the stomach, the intestines, the ureters, and the bladder. These are structures through which materials pass. Most of these organs contain food that is in the process of being digested, urine that is being passed to the bladder for release, or bile. When ruptured or lacerated, the contents spill into the peritoneal cavity, and this can cause an intense inflammatory reaction and possible infection called peritonitis. Peritonitis is serious and may become life-threatening, and the signs you need to look for include severe abdominal pain, tenderness, and muscle spasm. The small intestine is composed of the duodenum, the jejunum, and the ileum. The large intestine consists of the cecum, the colon, and the rectum. The intestinal blood supply comes from the mesentery, and it connects the small intestine to the posterior of the abdominal wall. Patients with injuries to the mesentery can bleed significantly into their peritoneal cavity, and signs of this include abdominal rigidity and periumbilical bruising, and this is known as Cullen sign. We'll watch the animation together. As you can see, organs spilling out from the stomach into the cavity produce bile, and this causes an issue with peritonitis. The solid organs of the abdomen include the liver, the spleen, the pancreas, and the kidneys. These are solid masses of tissue, and these organs perform the chemical work of the body. They produce enzymes, cleanse the blood, and give us energy. Because of the rich blood supply, hemorrhage of solid organs can be severe. Many solid organs are found in the retroperitoneal region, including the great vessels, the abdominal aorta, and the inferior vena cava. The retroperitoneal region also houses the kidneys, ureter, bladder, colon, and a majority of the pancreas. And here you see a picture of these structures found in the abdomen. Abdominal injuries are considered either open or closed and can involve hollow and/or the solid organs. With closed abdominal injuries, blunt trauma occurs without breakage of the skin. Some specific mechanisms of injury examples that you need to be aware of are the steering wheel, bicycle handlebars, motorcycle collisions, falls, blast injuries, and pedestrian injuries, as well as compression. Typically caused by a poorly placed lap belt, this creates an injury pattern called a clasp knife injury. It can also be caused when a person is run or rolled over by vehicles or objects. Also, deceleration, which commonly occurs when a person or the vehicle that he or she is traveling in strikes a large immovable mass, such as a larger vehicle, a bridge abutment, or the ground. Signs and symptoms of closed injuries include, the one thing you need to remember is that the pain from these types of injuries can be deceiving. It is often diffuse in nature, and it may be referred to another body location. The liver and spleen specifically refer pain to the shoulder. This is called Kerr sign when it involves injury to the spleen and pain in the tip of the left shoulder. Tearing pain from the abdominal cavity posteriorly may be a dissected aneurysm. Pain following the angle from the lateral hip to the midline of the groin can be the result of damage to the kidneys or the ureters. Pain located in the right lower quadrant can indicate an inflamed or ruptured appendix. And pain under the margin of the ribs on the right side or between the shoulder blades can indicate an injury to the gallbladder. Blood in the peritoneal cavity produces acute pain in the entire abdomen. The pain spreads as the blood or contaminant seeks out the voids in the peritoneal cavity, and often a jarring motion, like rebound tenderness or Bloomberg sign, will alert the patient to the peritonitis or inflammation of the peritoneum. Determining the location of pain or referred pain can be difficult when the patient has voluntary or involuntary guarding. Guarding is the conscious or unintentional stiffening of the muscles on the surface of the abdomen to avoid further pain, and it may be mistaken for abdominal rigidity. Abdominal distension or swelling between the xiphoid process and the groin is often the result of free fluid, blood, or organ contents spilling into the peritoneal cavity. Additional signs of abdominal injury are bruising and discoloration, and closed abdominal injuries may initially appear as abrasions. This may take minutes to hours for a contusion or a hematoma to become present on the surface, so that's why we don't always recognize them. Specifically, injuries from seat belts and airbags are an issue. Seat belts have prevented many injuries and saved many lives. However, they do occasionally cause blunt injuries of the abdominal organs. When you wear a seatbelt properly, it lies below the anterior superior iliac spines of the pelvis and against the hip joints. If the belt lies too high, it can squeeze abdominal organs or great vessels against the spine when the car decelerates or stops. It can also cause bladder injuries to pregnant patients who adjust the lap belt for comfort. In all current model vehicles, lap and diagonal belts are combined, so they cannot be used independently. However, people do still have a tendency to put the shoulder belt behind their backs and not use it. Airbags are a great advance in automotive safety, and they can be a lifesaver in a head-on collision. However, they must be used in combination with safety belts, and remember that children or small adults may be at risk of injury if the airbag deploys on them. As you can see here, some incorrect positions in the upper screen, and on the lower part of your screen, a correct position of the lap belt. Open abdominal injuries. Injuries in which a foreign object enters the abdomen and opens the peritoneal cavity to the outside. These are also called penetrating injuries or trauma, and stab wounds and gunshot wounds are prime examples of this type of mechanism. Open wounds can be deceiving. Therefore, you should maintain a high index of suspicion for unseen injuries, internal damage to organs, and potential life-threatening injuries. The injury will depend on the velocity of the object. The velocity can help predict the amount of damage to tissue. For low-velocity injuries, these are generally caused by handheld or hand-powered objects, such as knives and other edged weapons. Medium velocity injuries are caused by smaller caliber handguns and shotguns, and high velocity injuries are caused by larger weapons, such as high-powered rifles and higher-powered handguns. Medium and high velocity injuries have temporary wound channels in addition to exit and entrance wounds. This is caused by cavitation. Cavitation happens when a cavity forms as the pressure wave from the projectile is transferred to the tissues. This causes microscopic tears to the blood vessel and the nerves, and it can produce a large amount of bleeding. The higher the velocity of the projectile, the larger the cavity it produces. Low velocity penetrations also have the capacity to damage underlying organs. Internal injury may not be apparent during physical exam, and a bleeding wound may hide the fact that the object went further and deeper into the peritoneal cavity and injured other organs and tissues. You should remember that any time a patient has an injury at or below the xiphoid process, it should be assumed that both thoracic and peritoneal cavities have been violated. In evisceration, bowel protrudes from the peritoneum. This can be extremely painful and is also visually shocking. Do not push down on the patient's abdomen who has an evisceration, and only perform a visual assessment where there is any suspicion of this type of injury. You should cut clothing close to the wound and never pull on any clothing stuck to or in the wound channel. The signs and symptoms of an open injury include patients with abdominal injury having pain. Very commonly, you see tachycardia because the heart is increasing its pumping action to compensate for blood loss. Later signs include evidence of shock, such as decreasing blood pressure and pale, cool, moist skin, changes in the patient's mental status, and the abdomen may become distended from accumulation of blood and fluid. Blunt injuries should guide your attention to underlying structures because patients may have both closed and open. Bruises in the right upper quadrant may suggest liver injury. Bruises in the left upper quadrant may suggest spleen injury. Bruises to the flank may suggest kidney injuries, and bruises around the umbilicus, which is called the Cullen sign, are predictive of significant internal abdominal bleeding. Hollow organ injuries often have delayed signs and symptoms. Commonly, they spill contents into the abdomen and infection will develop, but this can take hours or days. The stomach and intestines can leak highly toxic and acidic digestive liquids into the peritoneal cavity. Both blunt and penetrating trauma can cause hollow organ injuries, and blunt trauma causes the organ to pop, which releases fluids and air. Penetrating trauma causes direct injuries, such as lacerations and punctures, and the gallbladder and the urinary bladder are hollow organs whose contents are potentially irritating and damaging if ruptured. These fluids move into loose spaces and voids in the peritoneal cavity, and they eventually lead to infection. Air in the peritoneal cavity also produces pain, and it can cause ischemia and infarction to tissue. Solid organs can bleed significantly and cause rapid blood loss. It can be hard to identify from a physical exam because the patient is not experiencing significant pain. Solid organs can also slowly ooze blood into the peritoneal cavity, causing pain to increase slowly over time. The liver is the largest organ in the abdomen, and it is very vascular and can contribute to hypoperfusion if it is injured. It is often injured by a fractured lower right rib or a penetrating trauma. A common finding during assessment of patients with an injured liver is the Kerr sign, which is left shoulder pain caused by blood in the peritoneal cavity. The spleen and pancreas are also very vascular, and both are prone to heavy bleeding when fractured, lacerated, or punctured. The spleen is often lacerated in motor vehicle collisions, especially in cases of improperly placed seat belts, steering wheel trauma, and falls from heights or onto sharp objects. Bicycle and motorcycle accidents where the patient hits the handlebars on impact are another type of mechanism. If the diaphragm is penetrated or ruptured, loops of bowel are likely to invade the thoracic cavity. This will cause bowel sounds to be present during auscultation of the lungs, and the patient may exhibit dyspnea or feel short of breath. The kidneys can also be impacted or penetrated by trauma, and this can cause significant amounts of blood loss. A very common finding is blood in the urine called hematuria. The blood is visible on inspection of the urinary meatus, and that indicates significant trauma to the genitourinary system. Patient assessment of abdominal injuries. Assessment of abdominal injuries is one of the more difficult assessments that you as an EMT will perform. The causes of the injury may be apparent, but the resulting tissue damage may not be so obvious. Patients may be overwhelmed with other, often more painful injuries, and some abdominal injuries develop and worsen over time, and that makes reassessment critical. We follow the same steps we've always followed in our assessment, and that is the scene size up, your primary assessment, take your history, perform a secondary assessment, and reassess. Often, information from dispatch will be sketchy or vague. Standard precautions should be taken at the scene, and this includes gloves and eye protection, and that should be at a minimum. Be sure the scene is safe for you. If assault, domestic dispute, or drive-by shooting is indicated, ensure that law enforcement has secured the area. Evaluate your mechanism of injury or investigate your nature of illness. You should observe the scene for early indicators of the MOI and consider early spinal precautions. You should also consider all of the injuries the MOI could have produced. The goal of the primary assessment is to evaluate the patient's ABCs and care for any life threats. The first thing you do is perform your rapid scan. This will help establish the seriousness of the patient's condition. Some abdominal injuries will be obvious and graphic, but most will be very subtle and will go unnoticed. Remember that in some cases of abdominal injuries, the injury may have occurred hours or days earlier. Form a general impression. Important indicators will alert you to the seriousness of the patient's condition. Trauma patients with closed abdominal injuries may have what appear to be minor injuries. You should not be distracted from looking for more serious hidden injuries. Check for unresponsiveness using AVPU and provide high-flow oxygen via a non-rebreather mask to all patients whose level of consciousness is less than alert and oriented. An unresponsive patient may have a life-threatening condition. Evaluate airway and breathing. You should ensure that the patient has a clear and patent airway. If you suspect spinal injury, you need to prevent the patient from moving. You should clear the airway of vomitus so that it is not aspirated into the lungs, and note the nature of the vomitus. The distended abdomen may prevent adequate inhalation, and by providing supplemental oxygen, this will help improve oxygenation. Evaluate circulation. Superficial abdominal injuries usually do not produce significant external bleeding, but the internal bleeding can be profound. Trauma to the liver, kidneys, and spleen can cause significant internal bleeding. You should evaluate pulse, skin color, temperature, and condition to determine what stage of shock your patient may be experiencing. And if the patient is in shock, they need to be treated aggressively. Make your transport decision. Abdominal injuries generally indicate quick transport to the hospital. A delay in medical evaluation may result in an unnecessary and dangerous progression of shock. And patients with abdominal injuries should be evaluated at the highest level of trauma center available. Investigate your chief complaint. Determine and investigate the chief complaint and further investigate the MOI. Also identify associated signs and symptoms and pertinent negatives. Note the position in which the patient is lying. Movement of the body or the abdominal organs irritates the inflamed peritoneum, causing additional pain. To minimize this pain, patients will lie still, usually with their knees drawn up, and breathing will be rapid and shallow. Obtain a sample history. You should use the OPQ-RST mnemonic to help explain an abdominal injury. If the patient is not responsive, attempt to obtain the sample history from friends or family members, and make sure to ask if the patient has experienced any nausea, vomiting, or diarrhea, and if so, ask how many times and over what period of time. Ask about the appearance of any bowel movements and urinary output, and determine if there was any blood in the urine or black tarry stools called melena. This will help determine if the patient has GI bleeding and if there is bleeding in the lower GI tract. Perform your secondary assessment. You may not have time to perform this detailed comprehensive exam in critically injured patients, but remember, with the physical exam, you should remove or loosen clothes to expose the injured areas of the body. Inspect the patient for bleeding before removing the clothing to prevent damage to exposed tissues. Provide privacy or perform in back of the ambulance. And remember, the patient should be able to stay in a position of comfort unless spinal injury is suspected. This will relieve some of the tension, and by placing padding under a patient's knees with a suspected spine injury, this will also help release the pressure on the abdomen. It can worsen the pain if you are too aggressive, and remember, your patient may be in a fetal position because this may be the position that is most comfortable for them if they don't have a spinal injury. Examine the entire abdomen, including all posterior, anterior, and lateral surfaces. This is a critical step for patients with an entrance wound. You need to evaluate bowel sounds. They can be difficult to hear, and if you cannot hear them, we call that hypoactive bowel sounds. And if you hear a lot of gurgling and the sounds of gas moving about frequently, that's hyperactive bowel sounds. Remember, though, that the evaluation of bowel sounds is considered to be of limited value to you in the assessment in the field. Use the mnemonic DCAP BTLS to help identify specific signs and symptoms of injury. Inspect and palpate the abdomen for the presence of deformities and look for the presence of contusions and abrasions. Puncture wounds and other penetrating injuries cannot be overlooked, and the intra-abdominal extent of these injuries may be life-threatening. You need to note the signs of burns and palpate for tenderness and attempt to localize to a specific quadrant of the abdomen. Treat lacerations with the appropriate dressings, and remember that swelling may involve the abdomen globally and indicate significant intra-abdominal injury. You need to palpate the abdomen when examining the region. You also need to remember that to palpate the quadrant furthest away from the quadrant that is exhibiting signs and symptoms of injury and pain, we start with the least injured or the least painful. This technique allows you to investigate the possibility of radiation and extension of the pain into the other quadrants. Perform a full-body scan to identify injuries other than abdominal injuries, and begin with the head and finish with the lower extremities, moving in a systematic manner. The goal is to identify the presence of other injuries, not the extent of those injuries. If you find a life-threatening issue, stop and treat it immediately. If the mechanism of injury suggests an isolated injury to the abdomen, you should focus your physical exam on the injured area only. Inspect the skin of the abdomen for wounds through which bullets, knives, or other missile-type foreign bodies have passed. If you find an entry wound, you must always check for a corresponding exit wound. Do not attempt to remove a knife or other impaled object. Instead, stabilize the object with supportive bandaging. Inspect and palpate the kidney area for tenderness, bruising, swelling, or other signs of trauma. Hollow organs will spill their contents into the peritoneal cavity, and these injuries will typically present as diffuse pain with guarding and reaction to sudden jarring movements. Many abdominal emergencies can cause a rapid pulse and low blood pressure. Your record of vital signs will help you identify changes in the patient's condition. You should use appropriate monitoring devices when available, such as pulse oximetry and non-invasive blood pressure devices. It is always recommended that you always assess the patient's first blood pressure manually with a blood pressure cuff and a stethoscope. Reassessment. You should repeat your primary assessment and vital signs and reassess your interventions and treatment that you have provided. Regarding your intervention specifically, manage airway and breathing problems based on the signs and symptoms found during the primary assessment. Provide complete spinal stabilization to the patient with a suspected spinal injury. And if the patient has signs of hypoperfusion, provide aggressive treatment for shock and rapid transport. If an evisceration is found, place a saline moistened dressing over the wound and transport. Never attempt to push eviscerated tissue or organs back into the abdominal cavity. A patient with a ruptured diaphragm may have an abdomen with a sunken anterior wall, and these patients should receive positive pressure ventilations with a bag mask device. Communicate all relative information to staff at the receiving hospital. And remember, appropriate medical and anatomic terminology is important. When in doubt, just describe what you see. Document the results of the physical exam and any pertinent negatives, and also document if you passed over any steps in the physical exam. It is imperative that you be able to describe the scene in enough detail to give the trauma team a clear idea of the circumstances. Your written report is a legal record of your care. Be cautious and diligent when dealing with patients who refuse transport after sustaining an injury to the abdomen or genitourinary system, because these patients are at a high risk for complication. Emergency medical care for abdominal injuries. The EMT's biggest concern is not knowing the true extent of the closed abdominal injury. These patients require expedient transport, and primarily they need to go to a trauma center with a trauma surgeon. Position the patient for comfort and apply high-flow oxygen. Always remember to treat for shock. A patient who has blunt abdominal wounds may have severe bruising of the abdominal wall, liver and spleen lacerations, rupture of the intestine, tears in the mesentery, rupture of kidneys or avulsions of kidneys from their arteries and veins, rupture of the bladder, and severe intra-abdominal hemorrhage. Peritoneal irritation and inflammation may also be present. A patient with blunt abdominal injuries should be log rolled to a supine position on a backboard, and we should take care to protect the spine. You need to monitor the patient's vital signs for any indication of shock and treat appropriately. A patient who has penetrating injuries generally has obvious wounds and external bleeding. You should maintain a high index of suspicion for serious unseen blood loss. Only a surgeon can accurately assess the damage, and you should assume the object has penetrated the peritoneum and possibly injured organs. Follow the general procedures described previously for care of a blunt abdominal injury, as well as inspect the patient's back and sides looking for exit wounds. Apply dry sterile dressings to all open wounds. And if the penetrating object is still in place, apply a stabilizing bandage around it to control external bleeding and to minimize movement of the object. Severe lacerations of the abdominal wall may result in evisceration, and this is where internal organs or fat protrude through the wound. You can see an example here in the photo of small bowel being eviscerated from the abdominal cavity. We never try to replace protruding organs. We keep them moist and warm with a moist, sterile gauze, and we cover the wound with that or an occlusive dressing. We secure the dressing with a bandage and secure the bandage with tape. The genitourinary system controls reproductive functions and waste discharge. Generally, we consider them together because the urinary system controls discharge of waste. Kidneys are solid organs. The ureters, bladder, and urethra are hollow organs. The genital system controls reproductive processes, and the male genitalia lie outside of the pelvic cavity except for the prostate gland and seminal vesicles. The female genitalia are contained entirely within the pelvis, with the exception of the vulva, clitoris, and labia. The reproductive organs allow for production of sperm and egg cells and appropriate hormones, the act of intercourse, and reproduction. You can see here a front and side view of the female reproductive system, and here is a front and side view of the male reproductive system. Kidney injuries are not unusual and rarely occur in isolation. The kidneys lie in a well-protected area of the body called the retroperitoneal space. A forceful blow or penetrating injury is often involved, and less significant injuries can result from a direct blow or even a football tackle. You should suspect kidney damage if the patient has a history or physical evidence of any of the following: an abrasion, laceration, or contusion in the flank, a penetrating wound in the region of the lower rib cage called the flank or the upper abdomen, fractures on either side of the lower rib cage or the lower thoracic or upper lumbar vertebrae, or a hematoma in the flank region. Very common type of football injury that we see. Urinary bladder injuries may result in rupture. Urine will spill into surrounding tissues, and blunt injuries to the lower abdomen or pelvis can cause rupture to the urinary bladder, particularly if the bladder is full and distended. In males, sudden deceleration from a motor vehicle or motorcycle crash can shear the bladder from the urethra, and in later trimesters of pregnancy, bladder injuries increase by displacement of the uterus. And you can see here an example of a bone fracture from the symphysis pubis of the fractured pelvis penetrating the bladder and rupturing it. Regarding injuries to the external male genitalia, soft tissue wounds are common, and these are painful and of great concern for the patient. They're rarely, however, life-threatening and should not be given a priority over more severe wounds. Regarding female genitalia injuries, the internal female genitalia involves the uterus, ovaries, and fallopian tubes, and these are rarely damaged. They are small, contained deep in the pelvis, and they are well protected. The exception is if the patient is pregnant and the uterus is engorged with the fetus. The uterus enlarges substantially and rises up out of the pelvis, and injuries can be serious because the uterus has a rich blood supply during pregnancy. You also must keep in mind the fetus is a patient. In the last trimester of pregnancy, the uterus is large and may obstruct the vena cava. Blood pressure may decrease, and the patient should be placed on her left side so that the uterus will not lie on the vena cava. External female genitalia include the vulva, the clitoris, and the major and minor labia, and the entrance to the vagina. They're very rich in nerves, and injuries are often very painful. You should consider sexual assault in pregnancy and ask the patient about their last known menstrual period. Ask about their sexual history, and remember the assumption is that all women of childbearing age are pregnant until proven otherwise. This information is relevant because some medications and tests are harmful for a fetus. In case of external bleeding and trauma, a sterile absorbent sanitary napkin or pad may be applied to the labia, but you should never insert instruments, gloved fingers, or a tampon into the vagina because these items can cause further damage. Patient assessment of the genitourinary system. The biggest issue here is the potential for patient embarrassment. You need to maintain a professional presence and provide privacy during assessment. If at all possible, have an EMT of the same gender perform the assessment and look for blood on the patient's undergarments, and only inspect the external genitalia when there are complaints of pain or external signs of injury. Our steps are the same. Scene size up, perform your primary assessment, take your history, Perform your secondary assessment and reassess. You should assess the scene for hazards and threats to crew safety, as well as assess the impact of hazards on patient care. Assess for the potential for violence and environmental issues, and at a minimum, you should wear gloves and eye protection. Minimize your direct contact with bodily fluids, and blood can be hidden under thick layers of clothing, and you need to remember this. Evaluate your MOI or investigate your NOI. Look for indicators of the mechanism. Consider how it produced the injuries expected. And remember, the patient may avoid the discussion to avoid undergoing a physical exam. Patients may also provide an MOI that seems less embarrassing than the actual MOI that occurred. During your primary assessment, you need to quickly scan the patient to identify and treat life threats. The genitourinary system is very vascular, and injuries can produce a significant volume of blood. Do not avoid this area in the rapid scan, and if bleeding is present, maintain privacy for the patient and inspect the exterior genitals for visible injury. Form your general impression. There are important indicators that will alert you to the seriousness of the patient's condition. The first thing to look at is the patient awake and interacting or lying still. Does the patient have any life threats? What color is the patient's skin? Is he or she responding appropriately or inappropriately? Evaluate airway and breathing. Ensure that the airway is clear and patent, and protect the patient from further spinal injury if trauma was involved. If the patient is unresponsive or has a significant altered level of consciousness, consider inserting an oral or nasal airway. Evaluate circulation. The genitourinary system can be a significant source of bleeding, and you need to assess pulse rate and quality, determine skin condition, color, and temperature, and check cap refill time. Closed injuries do not have visible signs of bleeding. Shock may be present. An assessment of pulse and skin will indicate how aggressively to treat for shock. Control bleeding if visible bleeding is seen, and significant bleeding is a life threat and must be controlled quickly. Make your transport decision. Any injury to the genitourinary system can be life-altering. It often requires a medical specialist for specialized care. Investigate your chief complaint when you're taking your history. Determine why 911 was called and avoid putting words into the patient's mouth. Some common associated complaints with genitourinary injuries are nausea and vomiting, diarrhea, hematuria, hematemesis, and abnormal bowel and bladder habits. Take your sample history. Also use the mnemonic OPQ-RST to learn about the patient's pain. Ask the patient about output from the system, especially urine, blood in the urine. Ask about allergies to medications or environmental triggers. The importance of past medical history cannot be overstated here, because repeated or previous injuries or illness can help determine the extent of the current injury or illness. The last intake of food and fluids is important because it can predict the genitourinary system's contents, and you should address the events leading up to the injury. Perform your secondary assessment. Do your physical exam, and remember these injuries can be awkward to assess and treat. Privacy is a genuine concern. If the patient has an isolated injury, focus on that and the body region affected. Look for DCAP BTLS and identify wounds and control bleeding. For significant trauma, start with a full body scan to see if there is trauma affecting multiple systems. The presence of penetrating injury indicates possible internal injury that should be managed accordingly, and the presence of burns must be noted and managed immediately. Palpate for tenderness to localize the injury in the presence of fractures, and look for lacerations and local swelling. Regarding vital signs, obtain the patient's vital signs. It is important to reassess vital signs to identify how quickly the patient's condition is changing. Signs such as tachycardia, tachypnea, low blood pressure, weak pulses, and cool, moist, pale skin indicate hypoperfusion. You should evaluate the need for rapid transport and also use pulse oximetry and non-invasive blood pressure devices if they are available. Perform your interventions in your reassessment, okay? You need to repeat your primary and recheck vital signs and reassess every intervention and treatment you have provided. This includes providing oxygen and maintaining a patent airway, attempting to control bleeding and treat for shock, placing the patient in a position of comfort and transport, and appropriately communicating and documenting what you've done. You need to communicate your concerns to the hospital staff, describe all the injuries and the treatments you gave, and documentation should be complete and very thorough. Next, we're going to talk about emergency medical care of genitourinary injuries. With kidneys, damage may not be obvious upon inspection. However, you will see signs of shock. You may see blood in the urine, and you need to treat for shock, transport promptly, and monitor vital signs en route to the hospital. Regarding a urinary bladder injury, you should suspect this if you see blood at the urethral opening, signs of trauma to the lower abdomen, pelvis, or perineum, and in the presence of shock or associated injuries, transport promptly and monitor your vital signs en route. Specific to external male genitalia, there are a few general rules for the treatment of these injuries. First of all, these injuries are painful and they do make the patient uncomfortable. Use sterile, moist compresses to cover areas that may be stripped of skin. Apply direct pressure with dry sterile gauze to control bleeding, and never move or manipulate foreign objects that are contained in the urethra. This does happen. Identify and take avulsed parts in a bag to the hospital with the patient. If the patient has an avulsion of skin on the penis, wrap the penis in a soft, sterile dressing moistened with sterile saline. Transport promptly. Use direct pressure to control any external bleeding, and try to save and preserve the avulsed skin. Regarding amputation of the penile shaft, you need to manage blood loss, and that is your top priority. Use local pressure with a sterile dressing on the remaining stump. Never apply a constricting device. Remember, surgical reconstruction is possible if you can locate the amputated part. Wrap it in moist sterile dressing, place it in a bag, and transport it in a cooled container without directly touching it to ice. If the connective tissue surrounding the erectile tissue is severely damaged, the shaft can be fractured or severely angled. Sometimes requires surgical repair, and the injury may occur during a particularly active episode of sexual intercourse. This is associated with intense pain, bleeding into the tissues, and fear. Accidental laceration of the head of the penis is associated with heavy bleeding. Local pressure with a sterile dressing usually stops the hemorrhage. The skin of the shaft or the foreskin can get caught in the zipper of pants, and this is common in young boys. If the small segment of the zipper is involved, you can try to unzip the pants. However, if it's a longer segment, use heavy scissors to cut the zipper out of the pants to make the patient more comfortable. Explain what you're going to be cutting, and be careful not to injure the scrotum while you're cutting. Urethral injuries in the male are not uncommon, and lacerations of the urethra can result from straddle injuries, pelvic fractures, and penetrating wounds of the perineum. It is important to know if the patient can urinate and if there's blood in the urine. You should save any urine for later exam at the hospital, and any foreign bodies that are protruding from the urethra will have to be surgically removed, and this is not done by the EMT. Avulsion of the skin of the scrotum may damage the scrotal contents. You should preserve the avulsed skin in a moist, sterile dressing for possible use in reconstruction. Wrap the scrotal contents or the perineal area with a sterile, moist compress, and use a local pressure dressing to control bleeding. Direct blows to the scrotum can result in the rupture of a testicle or significant accumulation of blood around the testes, and you should apply an ice pack to the scrotal area during transport. Female genitalia. You should treat lacerations, abrasions, and avulsions with moist, sterile compresses and use local pressure to control bleeding. Hold dressings in place with a diaper-type bandage and do not pack dressings into the vagina. You should leave any foreign bodies in place after stabilizing them with bandages, and remember that injuries are painful but generally are not life-threatening. In-hospital evaluation will be required, and transport urgency is determined by the associated injuries, the amount of hemorrhage, and the presence of shock. Rectal bleeding is a common complaint. Bleeding from the rectum may present as blood in or soaking through undergarments, or may be passed into the toilet with a bowel movement. Some possible causes include sexual assault, hemorrhoids, colitis, and ulcers of the digestive tract. And significant rectal bleeding can occur after hemorrhoid surgery. Acute rectal bleeding should never be passed off as something minor, and you need to pack the crease between the buttocks with compresses. Consult medical control to determine the need for transport. The last topic we're going to discuss is sexual assault. Sexual assault and rape are all too common. Victims are generally women, and sometimes men and children can be victims. Often there is little that you can do beyond providing compassion and transport. The patients may also have sustained multi-system trauma and will need treatment for shock. Do not examine the genitalia unless there is obvious bleeding that requires the application of a dressing. You need to follow appropriate procedures and protocol. Shield the patient from curious onlookers, and document the patient's history, assessment, and treatment, as well as response to treatment for possible court appearances. Do not speculate and record only the facts. Follow any crime scene policy of your EMS system, and advise the patients not to wash, douche, urinate, or defecate until after a physical exam. If oral penetration occurred, advise the patient not to eat, drink, brush their teeth, or use mouthwash until after a physical exam. Handle the patient's clothes as little as possible, and place articles of clothing or other evidence in paper bags. Do not use plastic bags because mold can grow and destroy evidence. Make sure the EMT caring for the patient is of the same gender if at all possible, and treat medical injuries and provide privacy, support, and reassurance. In summary for this chapter, you need to remember that abdominal injuries are categorized as either open, penetrating trauma, or closed, blunt force trauma. Either type of injury can result in injury to the hollow or solid organs of the abdomen and can cause significant life-threatening bleeding. Blunt force trauma that causes closed injuries results from an object striking the body without breaking the skin, such as being hit with a baseball bat or when the patient's body strikes the steering wheel during a motor vehicle crash. Penetrating trauma is often a result of a gunshot wound or a stab wound, and other mechanisms of injury, such as a fall on an object, can also cause penetrating trauma to the abdomen. Injury to the solid internal organs often causes significant unseen bleeding that can be life-threatening to your patient. Injury to hollow organs of the abdomen may cause irritation and inflammation to the peritoneum as caustic digestive juices leak into the peritoneum. A serious infection may also occur over several hours. Always maintain a high index of suspicion for serious intra-abdominal injury in the trauma patient, particularly if your patient is exhibiting signs and symptoms of shock. Assess the abdomen for signs of bruising, rigidity, penetrating injuries, and pain, and never remove an impaled object from the abdominal region. Secure it in place with a large bulky dressing and provide prompt transport. Be prepared to treat the patient for shock. Place the patient in the modified shock position, keep them warm, and provide high-flow oxygen. Never replace an organ that protrudes from an open injury to the abdomen, such as an evisceration. Instead, keep the organ moist and warm. Cover the injury site with a large, sterile, moist, bulky dressing, or use an occlusive dressing. Injuries to the kidneys may be difficult to detect because of the well-protected region of the body where they are located. Be alert to bruising or a hematoma in the flank region. Injuries to the external genitalia of male and female patients is very painful, but not usually life-threatening. In the case of sexual assault or rape, treat for shock if necessary and record all of your facts in detail. Follow any crime scene policy established by your system to protect the scene and any potential evidence. And advise the patient not to wash, douche, or void until after a physician has examined him or her. Thanks for your attention, and as always, any questions you have about this lecture can be directed to your instructor in the classroom setting.